I'm going to set the stage by talking about screening and surveillance, which is a good place to start with Barrett's. And I'll start with this statement, which I found in one of the gastroenterology journals, which I thought was very good and quite telling. And you can read it here. It's a wonderful place to start and couldn't be more true. This is a highly volatile part of the epithelium of the GI tract. And therein lies the interest in screening and surveillance, if you will. Start with definitions. Screening, very different than surveillance. Screening is finding a disease in a population that may or may not be at risk, usually is at risk, that doesn't already have it. Surveillance is following a patient that has a disease. Two very different things, and I'll break them up into two parts here. As you probably know, screening for Barrett's esophagus, as far as I know throughout the world, is not current standard of care. As this AGA news announcement points out, the AGA is actually just in the midst of crafting its guidelines on Barrett's esophagus. I have the privilege of being on that committee. Should be out sometime later in this fall, and endoscopic screening for Barrett's will not be part of it. There is a little bit of dissent in the GI world about that, as I'll show you. There is data, however, with regard to the cost effectiveness of screening. There is considerable variability in the data. There's 5 U.S. studies that have been published. I'm going to show you 2 of them. And they're all dependent upon a number of variables. Firstly, none of the data that looks at screening addresses the general population, as you might imagine. It all addresses a high-risk population, and that high-risk population is almost always defined as white males over 50 with more than 5 years of reflux symptoms. Reflux symptoms. That's an important distinction. And there are a number of assumptions that go into all the cost estimates that then determine public policy. And their assumptions vary considerably from study to study, and you'll see sometimes tens of thousands, if not even hundreds of thousands of dollars difference in some of the conclusions, partly based on the assumptions. And you can see here how if you move this bar based on some of these assumptions, like the age of the patient, or if you will, the resectability of the cancer, you can go from anywhere from about $12,000 in incremental cost effectiveness to up into the 50, 60, and even hundreds of thousands of dollars of incremental cost effectiveness. And recognize also that in all those assumptions, there are no prospective randomized data with which to draw. So the underlying basis for the assumptions is tenuous. But there is some data, and here you can see one of the papers that was published, assuming a Barrett's prevalence of 10%, a cancer incidence of 0.5% per year, 2.5% per year in high-grade dysplasia, and a $450 upper endoscopy cost, concluding that it's about $25,000 per quality-adjusted life year saved if you're going to screen for Barrett's esophagus in a 50-year-old white male with GERD, as I mentioned. Now that compares reasonably, that number compares reasonably with other screening decisions that have been part of public policy for some time. You'll notice here numbers anywhere from about $40,000 a year to as low as $2,000 a year. I'll also point out that the measure here changes. It's one of the problems with comparative data in this field. Life year saved is not exactly the same as quality adjusted life year, which is not exactly the same as life year gained. You get your arms wrapped around your axle pretty quickly trying to compare some of these things, but nevertheless, there's ballparks that you can see. So $25,000 is a reasonable ballpark for that particular study. And the studies vary anywhere between about $12,000 to $15,000, as I showed you in the Inodomi study, up into the hundreds of thousands of dollars, depending on the population and the assumption. There are significant problems, however, with the public policy of Barrett's screening, and they're on this slide. It excludes patients with minimal or no symptoms, which is arguably a very important population. Most of you in this audience who've seen patients with esophageal adenocarcinoma have seen those whose symptoms are minimal or absent. They're there, and it would exclude that population. Defining Barrett's is a problem, and it's very endoscopically subjective. And 2/3 of Barrett's, as we currently stand in 2010, is short segment. There's significant endoscopic and histologic error. There's resistance to add anything to healthcare costs these days. And if we did screen for Barrett's, one of the issues is it would significantly add to the surveillance population. And whether there's even a workforce to do that is a question. And then the final challenge is the issue of getting patients, or the population, if you will, to comply with any screening program. And here's recent data on the penetration, if you will, of U.S. adults in 2008 for other nationally recommended screening programs, and you can see that it's roughly about half of the population is screened, and about half the population, for one reason or another, elects not to comply with screening. So at the best, we'd only get half of them, at least at first. We fall with this. This is the American Society of Gastrointestinal Endoscopy, a little bit more flexible recommendation, if you will, than the AGA's recommendation for screening, that I think is more realistic common practice these days than the AGA and AGA's recommendation. And that would say that screening is reasonable in a patient that you think may be at high risk. And I think that's probably the case in most of our practices. If you see someone who's had reflux symptoms for more than 4 or 5 years, particularly a white male these days, it would be unusual for a practitioner not to pursue upper endoscopy, although there's no official recommendation to do that. Now I'll move on to surveillance in somebody that has Barrett's esophagus, seen here. There are 3 societal guidelines. Actually, there's probably 4 or 5 if we include the surgical societies, the American Society of Thoracic Surgery and SAGES and others, which I haven't, but I'm going to show you the American College of Gastroenterology guidelines, which are as good as any and probably the most commonly followed for surveillance of Barrett's now. And that is 2 upper endoscopies within the first year, because there is an emerging body of evidence that would suggest that you don't know exactly how it's unfolding when you capture the patient, and you ought to cohort the surveillance a little bit more closely in the first year, and then every 3 years thereafter. I'll show you in a moment that that number ought to be softened a little bit. If you have low-grade dysplasia, it ought to be repeated with biopsies within 6 months, confirmed by an expert pathologist, and then perhaps 1 year until no dysplasia is identified. These days, that's often treated. If you have high-grade dysplasia, the current recommendations are a therapeutic intervention by and large, not surveillance. Although if you are going to surveil somebody with high-grade dysplasia that perhaps is high risk, it would be every 3 months. So basically, every 3 years if there's no dysplasia, and more frequently if there is dysplasia. I just want to challenge the every 3-year number a little bit and point out that every 3-year data comes from the relative risk of developing a cancer in someone with Barrett's esophagus that's currently assumed to be somewhere between 5 per 1,000 and 1 per 1,000, this green bar right here. But it is not the same in every individual. Following someone with short segment Barrett's esophagus is not the same as following someone with 12 centimeters of Barrett's esophagus, or with a family history of esophageal cancer, or with other mitigating factors perhaps, or someone who's had dysplasia sometime in their past. So I would encourage you all to consider the individual patient factors into that 3-year mark, because if you surveil everyone every 3 years, I think that's probably too long. The standard of care is to take 4 biopsies around the clock face every 2 centimeters in non-dysplastic Barrett's and every 1 centimeter in dysplastic Barrett's of the biopsy for surveillance. And if you do that, there's reasonable data, along with biopsying any visible lesion, that you will have a virtually certain chance of picking up areas of neoplasia. And that's probably true. There's been a lot of work going on gone on for decades with various focal methods of vital staining and other things. But if you just biopsy in that fashion, you'll probably pick up most of what you need to see. What's the probability of then finding an issue? It's about 5% per year is a good number to have in your brain. That's a substantial proportion of the patients, 5% per year. If you're following 100 patients with Barrett's esophagus, 5 of them every year will deteriorate into low-grade or high-grade dysplasia. 4 of that 5% is low-grade, 1% is high-grade, and a small percentage, as I said, 0.5% or so is going to be cancer. Here's one of the best pieces of data from the Cleveland Clinic registry following a cohort of Barrett's patients that started out of about 150 patients over 10 years. And you can see it's just about that. 10 years, 50% of the patients had developed neoplasia, defined by any dysplasia or cancer over a cohort of 10 years. I think that's just about right. The fundamental rationale for surveillance is the fact that we'd pick up neoplasia early, treat it, and presumably prevent that patient from dying from esophageal cancer. Here's a compilation of papers that were published mostly in the 1980s. Here's the survival for those that had esophageal cancer found on surveillance. Here's the survival of those who had esophageal cancer found without surveillance. And you can see there's a dramatic difference between the two populations. If the cancer is found in a patient on surveillance, the chances of you surviving that esophageal cancer are much higher. There's no question about that data. It's not debated. But it is debated if you ask the question in a different way, which is often done. And this is an editorial that begs that question a little bit more. And this editorialist says he is going to present a skeptical view of the surveillance recommendations by focusing on the only management outcome that matters, whether we prevent death or not in esophageal cancer patients across the entire population. The other slide I showed you was the numerator, not the denominator. And in fact, if you look at a different compilation of studies, and you look at deaths from all causes, deaths from esophageal cancer, and the percent of deaths from esophageal cancer, and whether patients were surveilled or not, there isn't as dramatic a relationship. There isn't as dramatic a relationship between those that were surveilled and those that weren't surveilled. Now we're looking at the denominator and not necessarily the numerator, and therein lies the genesis of some skepticism about whether surveillance, let alone screening, about whether surveillance for Barrett's esophagus is an issue. And let me bring that home with 2 further points, and then I'll finish. This is, I find this fascinating data. This is the perceived efficacy of screening and surveillance for esophageal adenocarcinoma from a cohort of gastroenterologists. I think this is from the UK. And you can see here that they cluster down on the low probability of helping the patient. Most gastroenterologists in this survey weren't too clear on whether they were helping them or not. Here's the perceived efficacy of screening for colorectal cancer. Very different in the gastroenterologist's mind. Here's the risk of developing cancer if you have Barrett's and the risk of developing colon cancer if you have a polyp, and they are virtually identical. There's a little bit of a disconnect there between the perceived benefit on both sides of those coin, both sides of that coin. And in fact, if you survey the prevalence of surveillance and even the proper surveillance, you'll find that it's not highly penetrated either. That's another problem. If we do it, can we get the community of physicians at large to do it properly? And that's a challenge. In fact, that challenge has been taken up, and with quality assurance efforts, one can improve those numbers. Again, this is a focused effort from Europe, I believe, showing that you can start low, and with education of the physician population, by and large the gastroenterology population, you can improve the ability to surveil. So I'll finish with this slide, which I think sort of sums up the whole philosophy. Again, I think a well-written editorial that was published in the last few years. The data are conflicting, the data are complex, and the questions are significant. And when you have such a circumstance, I think this individual said it very succinctly and very correctly. We concede that the practice, and here he's talking about surveillance, is expensive from a third-party payer's view, and perhaps you can add from a societal view. However, from a social perspective, the combination of the unknowns and our responsibility to advocate for the patients makes not doing it premature. And in the absence of good data, we ought to consider the glass half full, not half empty, and I couldn't agree more. Thank you very much.